Thanks, Mohammed, for organizing this, and I'm grateful to you for inviting me. I'll give you perspectives which, from the institute side and from the Asian side, we have very good faculty and bright residents, and put us next to AIMS Delhi in research outputs. I'll briefly cover some topics and discuss others. The important part is you have a patient who has normal liver, he goes to ALF, he is decompensated cirrhosis, he gets acute insult, and he gets further worsening. So there's a natural history of decompensated cirrhosis, whether bleed, AKI, HE. You have a group of chronic liver disease who present with jaundice followed by ascites, and another group of compensated cirrhosis who get acute insult. They can have several presentations, bleed, HE, ascites, HRS, sepsis. We are only discussing at least APASL and ARC as one part of the acute decompensation, that is jaundice, followed by ascites and acute portal hypertension syndrome, which is homogeneous, unlike Cliff, where you have almost nine combinations of this, and also the next cell, which is a different disease, a spectrum of patients with decompensated cirrhosis. So we are not sure who and which group and which category is right, but here it is jaundice followed by ascites. The basic definitions, there are some changes between the two. It is 4 to 12 weeks of two or more extrahepatic organ involvement with high mortality in 3 months' time and includes decompensated cirrhosis as well and includes SIRS and bacterial infection, while the APASL and ARC is an acute hepatic insult and the time frame is 4 weeks and it includes ascites and or HE, but not sepsis as a precipitating cause. So why do we need to debate and what is in a definition? It's like Muhammad Rela UHID this, so you know this is Muhammad, this is his photograph. We need to have a correct phenotype to have a proper treatment. I'll briefly discuss this case. This has been done before also. But here is a 33-year female who had been taking one of these indigenous medicines, developed jaundice for 5 days and ascites for 2 days, had a liver of 13, nosebleed. On 23rd day, the patient presents as low platelets slightly and bilirubin of 22, disproportionately high ALT, and normal create. The patient was given standard therapy and diuretics because of ascites, which was massive, and patient had to be given albumin and had a modest volume paracentesis. There was no SIRS at that time. Now, on day 27, 4 days later, patient had a high heart rate, has INR which has increased, create is slightly rising up. She undergoes a transjugular because she had no varices, and transjugular showed that she had F3 fibrosis. Liver was coarse. Patient was given standard therapy and NAC because she had been on maybe DILI as one of the criteria. Now, on 4 days later, this patient now has a bilirubin, which is 31. Now, create is going up to 1.8. So, the one organ failure in addition to liver. So, now this patient would qualify according to Cliff as a ACLF. She has repeated MVPs and liver transplant prognosis was explained. About few days later, this patient now has achieved pneumonia, needs vasopressors, and she died on day 36. What APASL would have done on 23 day would to score her, but EASL would do maybe on day 30 to tell need for a transplant. So fundamentally, the difference is APASL ACLF comes earlier when other organs have not failed. Only liver failure is the main problem. However, Cliff will start with liver failure plus minus and other extrahepatic organ failures. So this is what a beautiful hepatology paper from the US, Nadeem, had said, that APASL might find ACLF 2 to 6 days earlier. We believe it is about a week earlier than EASL. Let's look at the canonic study carefully. Here, 303 patients at entry had ACLF, 112 developed it much later. So totally 415 patients had ACLF. Mortality at 90 days was about half. Now, what is important is when the patients were categorized, the single organ failure as liver was only 14%, and kidney failure was about 19% or so. So this means a large number of patients, 85% of them, had no liver failure. Although at presentation, three organ failures were there. So other than liver, we had cerebral, coagulation, and other failures. And that is a huge difference between the two groups profiles of defining patients. About organ failure, way back in 2012, we were able to show on the small database that patients who have two organ or three organ failure, survival would be much, much lower. So organ failure is clearly something which defines death. So this is the summary from Nadeem's paper in hepatology. Choices are getting clearer. He says, we argue that a more liver-specific definition would not only preserve the syndrome's face validity, liver failure, and therefore it should affect the liver, but also would be clinically more useful. Now, one of the slides, this slide shows you that we did a survey of about 84 transplant centers in Asia and the rest of the world. And the major reason for saying that we cannot do transplant is more than true organ failures or presence of sepsis. Both of these will say transplant cannot be done. So let me summarize this part of the talk that we need to define a pure phenotype of ACLF. Liver is the core. And organ failure, do we need it? For defining ACLF, no. We will lose, we will be late. For prognosis, certainly we need a organ failure score. And decompensated cirrhosis in our mind has a separate natural history. And sepsis is a result of the inflammation and SIRS. Now, is there a potential of reversibility in them? Possibly, yes. Let's look at first the severity assessment. The ARC score, APASL, ACLF Research Consortium score, has 4 parameters from liver, jaundice, coagulopathy, encephalopathy, and lactate. And creatinine is a consequence or corunner for this score. Now, this is the first score where liver failure has been categorized in chronic liver disease. Our patient, when the patient came to us on day 23, had a bilirubin of 22.5, no HE, but INR was high, lactate was high, and create was normal. The ARC score based on this was 10, and he had grade 2 of liver failure, means a score of 10. Now, 4 days or 7 days later, this patient now had INR high, lactate was still high, and creatinine started becoming worse. And this patient, therefore, got a score of 12, and that means was grade 3 liver failure. And this is simple bedside, no more calculation. Why I'm showing you this slide is that if the baseline score of a ACLF patient of ARC is 10, if it becomes 11, mortality increases by 20%, 12, another 20%. So simply on day 4 or 5, you can start seeing this dynamic score and how this score can make a difference in our approach. The score for Dilly, that is our patient, was calculated and was published in American Journal about 2 years ago, that ARC score for ACLF probably scores better compared to all available scores. It's a simple bedside severity score. What it shows is one more time the relevance of coagulopathy, relevance of lactate and HE in the determination of this. And this patient of ours was ACL FDL, but holds true for alcohol or for other etiologies. The mortality based on the ARC grade 1, 2, and 3. ARC grade 3 mortality is higher in these patients. At 30 days, it comes to about 30%. Easy to remember. Now, this is a very important paper which came from Professor Duseja's group that a 30-day mortality in ACLF is dependent on a large overweight and obesity. So we need to remember that this has to be factored in. Whether this is true for children, especially for Wilson disease, this was calculated and R score of 11 or more has a higher mortality and scores better than other available scores. Whether infection or sepsis is a result or a cause, you can always debate that, but generally, SIRS can lead to organ failure directly. SIRS can also lead to sepsis, or sepsis can lead to organ failure. We have about 7 days' time, and the mortality is slowly from day zero. These are the people who do not have SIRS but have no infection. By day 4 or day 7, you will see the number of people with SIRS and sepsis increases. So if the patient has come to you as a third referral, fourth referral after many days, of course you will say, yes, patients with ACLF SIRS or sepsis. But if it comes early, you may have no SIRS, and this is the time you actually can work. So our golden window is about 7 days. If patient is referred to you after 15 days, obviously all complications will be there. Now let's look at the new treatment options. We in the nutrition field for the first time were able to show that giving omega-3 or omega-6 even in deeply jaundiced patient is safe. These were given for 3 days. In fact, omega-3 worked as an anti-inflammatory and was able to improve survival compared to control groups. The important part of whether a autoimmune hepatitis, I know there is a separate lecture by Professor Neuberger. We need to see that patients who have got a flare of autoimmune and have ACLF, and if the MELD is about 27 or HE is present, and there is an F3 fibrosis without cirrhosis, this patient will need a transplant. Less than that, let's say MELD of 25, 26, and not HE, one can try the steroid therapy, but be very careful to list them above 20 MELD. There are several challenges in the ACLF management. I'll rush through some of these concepts. First is the treatment of acute portal hypertension. A patient with cirrhosis has high portal pressure. Once there is liver cell failure in a cirrhotic patient, there is sudden rise in portal pressure, adds to increased cytokines, active stellate cells, endothelial dysfunction, and impaired vascular relaxation. And this leads to sudden rise in pressures in the portal system, development of ascites, HRS, GI bleed, and HE. There is intense systemic inflammation, and this is partly because of hyperbilirubinemia, high bile acid levels, and this is a syndrome which is distinct from a decompensated cirrhosis with just kidney involvement and sepsis and no jaundice. It has intense inflammation and rise in pressures, high cardiac output, rapid rise in HVPG. Now, patients who improve in ACLF and have no varices, this is an important data. This is a reversible syndrome. During ACLF, when they presented with no varices, HVPG was 15. After recovery in about 2 to 3 months' time, these patients have spontaneous reduction in portal pressure. So this is a reversible, this is the dynamic component of portal hypertension. So the question which we had few years ago, if you treat this acute portal hypertension with beta blockers, can you improve the outcome? So patients who had either spontaneously regressed within their portal pressure or after giving carvedilol. We found that if the pressure has decreased to more than 20% or so, varices are only 9%. But if the pressure has not decreased, varices will progress or develop. Also, we found that if the carvedilol has been used in acute portal hypertension, the reduction in SBP, pneumonia, and AKI was evident and led to an improved survival in beta blocker effective group than placebo group. Now, a new concept has come of preemptive tips in a patient who has large varices. I told you about small or no varices. A large varices patient who has bled. And this interesting paper by Jonelle Trebetha has shown us that if you do preemptive tips early enough in these patients, the survival with preemptive tips is better than those who do not have tips, and therefore there is a possibility of using the tips in these patients. Let's come to the second part of acute portal hypertension, that is ascites. Normally, patients get in ascites tense LVP. We had a hypothesis that ACLF patients have more paracentesis induced circulatory dysfunction, and therefore, because of intense inflammation, therefore, a modest volume paracentesis of 3 or 4 liters should be done. Albumin was given or no albumin, and we found that in patients with ACLF, still 30% of the patients get PICD with albumin. Without albumin, 70% or so. So we strongly recommend first modest volume paracentesis of 3 to 4 liters and also to add albumin in these patients. This important paper in hepatology added a new term, MVP from LVP. Now, patients have progressive liver failure, bilirubin of 20, 25, 30, coagulopathy, and high lactate and HE. Can you do something in them? And this recent publication shows the relevance of therapeutic plasma exchange, which can help reduce, ameliorate SIRS, and prevent multi-organ failure. So, what is the rationale? It detoxifies biosynthesis and homeostasis. All these three can be achieved by plasma exchange. Now, this is to show you those who responded to plasma exchange versus those who responded versus non-responded. There is a significant change in the cytokine profile, and also the DAMPs, HMGB was decreased, IL-1RA was significantly improved, endotoxin levels came down, and monocyte functions improved. Very importantly was the bioenergetics. Plasma exchange re-energized. This is the amount of oxygen mitochondrial function which could be recovered on seahorse. The plasma exchange in responders made your monocytes more phagocytic, more important. And this showed the benefit of giving plasma exchange compared to Prometheus and others. There was an improvement in survival with plasma exchange up to 90 days time. I have shown you some of these concepts. Now for infection, very briefly I'll touch. There is an immunopoiesis of neutrophils, monocytes, DCs and T cells, and that leads to a consequence. Our earlier work showed by giving GCSF, you may improve the DC function. You may also reduce the neutrophil dysfunction, which allows sepsis and other complications to develop. However, much more is required because we have different opinions across globe, and I think more studies are required in this direction. For HE, one more time, plasmapheresis and ammonia targeted therapy. For ALF, above 120 ammonia is considered to be high. For ACLF, we have shown 143 to be high. For AKI in ACLF, the APASL feels that there is a need for recognizing early use of vasoconstrictors once there is no relief from albumin. and the response to terlipressin is only in about 35% or so. So two-thirds of them will not respond, and we have to consider alternative therapies in them. Liver transplant, of course, and this being a transplant, ILTS and Dr. Ella's initiative is an important part. Now, this slide, this paper, which is just in press now, shows you that from the ARC registry of APASL, at baseline, 196 patients out of the whole selected group were transplant acceptable. What is done is that if you admit them in an ICU, you can make this number double. You can stabilize a large number of patients to become stable and become transplant candidates. Now, if you are a transplant candidate, but you do not get a transplant, then you die, and you die early enough. The hazard ratio is high, but if you get a transplant, of course, you would survive. The number of organ failures over a period of time will keep increasing from single to two or three. And if you have three organ failures, the mortality will continue to rise. This slide I've already shown you about more than two organ failures or sepsis being not accepted for transplant in many centers. So this is my last slide to show you the current management algorithm that we believe a patient has come with an R score about 10, that means 11 or so, he would need to be considered for a transplant right away. And if there is any sepsis or organ failure, we need to optimize. Let's say within 7 days, the ARC score has come down. And if ARC score has come down, you may actually wait, may allow them medical therapy also. But if it is increasing or has not changed, of course, an emergency transplant needs to be considered. I don't think there would be any debate on that. This is the way a patient with a high ARC score needs to be followed. If the patient has come to you with easy definition of two or more organ failures at the beginning, well, if the patient is stable, you can stay right away for transplant. Or if there is a need, one can try plasmapheresis to stabilize this patient. If he is not improving, of course, supportive care because it may be too late. But if the patient has already, four or more organ failures, you need just simple supportive care. So I just want to emphasize that the journey for ECLF is long. I know we have different opinions, but Rajiv remains an extremely respected and dear friend, and of course all others in the European group. But we just want to emphasize that yes, liver is the core. Liver failure must be the major part of the management of ACLF, and more than 7,000 cases are already registered in the ARC, no money. With just efforts, I think the initiative is going to many parts of the world. And thank you all for your attention. And I'll be happy to take any questions now.